With everyone's permission, I'm starting with today's live now.
I think Dr. Sarani, yeah, she joined.
Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Neonate, serving as an allocated session assistant to ensure a seamless experience. Neonate is India's most trusted and widely used tech platform, offering a multitude of imaging services exclusively for the doctors. Neonate is later to be chosen as a digital partner for this event organized by National Neonatology Forum Gujarat. So today's focus would be new ground rounds, gray zones. Let's begin today's session, for which I would like to invite Dr. Viraj Thakkar ma'am to take over. Over to you, ma'am.
Thank you, Clarinet. Good afternoon, everyone. It is my great pleasure to welcome you again at the same series, that is the next Neonatal Pathshala. And without much delay, I request Dr. Yogesh Parikh, sir, who is working at Government Medical College, Surat, and sir is the
Virat
president of
Chal,
NNF.
Virat Chal. Just
And
NNF
yeah,
is enough.
that's it. Over to you, sir. Yeah.
Yeah, okay. Thank you, Dr. Biraj, NNF Gujarat Secretary. Uh, Respected our chief guest, our own NNF President, Central NNF President-elect Dr. Somsekhar Nimbarkar, guest of honor Dr. Rajesh Kumar from our IAP Neonatology chapter, our esteemed faculty Dr. Saranya and Dr. Anish Pillai, today's moderator Dr. Viraj Thakkar, and all the colleagues and the dear friends who joined on this digital platform. It is an immense pride and privilege to welcome you all for this flagship academic initiative of the NNF Gujarat Neonatal Pathshala and the Neo Ground Round, which is the brainchild of our own secretary, Dr. Biraj. So this is a series has become the hallmark of the structured, highly quality academic learning. And today's topic is gray zones, real cases, real dilemmas, and real learning. So it reflects the very essence of the neonatology. In neonatology field, decisions are rarely black and white. They demand wisdom, evidence, and above all, the collaboration of all. So nurture collective learning. Each case we discuss is not just a clinical puzzle, but an opportunity to refine our judgment and to strengthen our commitment to the newborn care. So, let me take a moment to acknowledge our faculty member, Dr. Saranya and Dr. Anish, for their expertise in this field to bring the clarity to the complexity. And our moderator, Dr. Biraj, whose dedication as secretary and the project in charge has been instrumental in shaping this platform. Our national leaders, whose presence today inspire us to align Gujarat's efforts with the broader vision of the NNF India and the IAP Neonatal chapter. So friends, this is Neonatal Pathshala is more than a CME series, uh, moment of the academic excellence and the transparency and the unity. It reflects the spirit of the Gujarat where the teamwork, innovation and the inclusivity drive the progress. I thanks here Dr. Ronak also for his constant support to the NNF Gujarat team. I reaffirm our commitment to the empowering young neonatologists with the structured learning, fostering collaboration across the institution and the regions, upholding the democratic values within our organization, ensuring that every voice contributes to our collective mission. So thank you, team NNF Gujarat and the whole Central NNF and our IP Neonatal chapter, all the faculties. Thank you, Jai Hind. Over to you, Dr. Biraj.
Thank you, sir, for valuable words. Now, moving forward, I request Dr. Ronak Patel, who is the backbone for coordination of this program, along with me. So, he is a program coordinator. He's a consultant neonatologist, Palanpur, and now I request him to take this program forward. Ronak.
Yeah, thank you, Dr. Biraj. So, without much delay, I welcome our today's eminent chief guest and President-elect 2026 NNF India, Professor Dr. Somsekhar Nimbalkar, sir. Welcome, sir, for today's session. He is a professor of Department of Neonatology at Pramukh Swami Medical College, Karamsad, Gujarat. He is President-elect 2026 NNF India and Editor-in-Chief of Journal of Neonatology. He was a national coordinator and national convener of IAP NNF NRP program for many years. Internationally, also, sir is a member of IPS program on maternal and newborn health and education, and also a member of ILCOR Neonatal Life Support Task Force. Sir is also a founder, trustee, and joint secretary of KMC Foundation of India. And there are many publications, more than 160 in a PubMed indexed journal, as well as more than 250 research presentation on his name. With this profound experience in the neonatology, sir has established the Department of Neonatology and led the first DM neonatology program in the Gujarat. With this, I request Dr. Somsekhar, sir, to bless us with the words of wisdom. Over to you, sir.
Thank you, Dr. Ronak. I would like to actually acknowledge first the start of this program somewhere in I think 2020 or 2021. This Neonatal Pathshala, which began initially due to the COVID, and it has made rapid strides over the last 6 years, morphing into a very well followed program across India. A lot of the recordings, and that's initially it just began as case studies or case presentations, and now we have journal clubs, grand rounds, seminars, journal clubs, quizzes, and so on and so forth. And with every subsequent president, there has been some more innovation in the program. So Dr. Biraj started this Neo Grand Rounds, I think, about 3 years back, and that was very well done. And I think it is a good thing that we are continuing this process where we are discussing relatively complicated cases and what should be the best way to be going about managing these cases. So it's a very interesting concept. We also have some nurses training program which is going on. So all of this is contributing to a rich amount of collected educational material on the YouTube channel of Gujarat NNF, and I would urge everyone listening to this to visit the YouTube channel, give it a like, subscribe, and follow so that you can get the latest. Whenever the new episode comes up, you can see that, because it is often not possible for everyone to join in at 3:30, but you would have enough time to do it at a later period of time at maybe even 1.5x times so speed. So thank you again, Dr. Ronak, Dr. Yogesh, and Dr. Biraj for inviting me, and I look forward to a very engaging session from Dr. Saranya and Dr. Anish, who have contributed in many ways to neonatology in India. Thank you for agreeing to come as faculty, and I hope we all learn from your presence here. Thank you. Back to you, Ronak.
Thank you, sir. Thank you for your words of wisdom. Now, for today's session, we have a guest of honor, Dr. Rajesh Kumar, President of IAP Neonatology Chapter India, and he is a DM Neonatology from PGI Chandigarh and a Director and Neonatologist at Rani Hospital, Ranchi, which is one of the leading pediatric hospital in the Jharkhand. He is also Executive Board Member of NNF India. He is also Secretary of Association of Healthcare Providers of India of Jharkhand State. And there are more than 16 publications in the index journal with his name, and he has authored 12 chapters in different books. And he is also a national faculty for many neonatal conferences across the India. Now I request Dr. Rajesh to say a few words for today's session. Over to you, Dr. Rajesh.
Oh, thanks, Ronak. And it's my first time I'm joining this Neonatal Gujarat's NNF Gujarat's Neonatal Pathshala, and so hopefully it is going great for last 3 years, and as such grand rounds, na, usually it is very interesting because whenever we do grand rounds in our hospital also we did discuss the difficult cases where we had diagnostic dilemma mainly. And over the years, what I have learned, each case is different. Each case faces the new challenges to you. And baby, I always tell my resident that baby, they don't come reading the books. You have to apply your mind. You have to discuss with seniors and juniors. And then you decide what to do. And hopefully today also we'll learn from the cases. And Anish and Saranya will help in decoding the case. Thanks for inviting me. Thank you.
So thank you, Rajesh, for the joining first time in the NNF Gujarat. But in the AOP Gujarat, while I was the president in 2021, we started the E-Gurukul Pathshala.
Yes.
And subsequently, we started in the NNF Gujarat Neonatal Pathshala.
Okay.
So, yeah,
Thank you, sir.
thank you, thank you. Welcome to Gujarat. Yeah, over to
Thank you,
Dr.
Rajesh, sir. Yes, sir. Yes, sir. Thank you, Dr. Rajesh, for your kind words. Now, I request Dr. Biraj, our young dynamic secretary of NNF Gujarat and project in charge for Neo Ground Rounds, to take the session forward. Over to you, Dr. Biraj.
Yeah, thank you, Rona, for coordinating. And as a part of Neonatal Pathshala, today we shall be discussing about Neo Grand Rounds, conducting the Neo Grand Rounds, which is basically a case-based discussion where we are going to discuss real cases, real dilemma, and real learning from those cases. So today we have Dr. Anish and Dr. Sharanya with us to discuss such kind of a cases, which would encourage the thought process and finally reflect in our clinical decision and learning. So, welcome, Dr. Anish Pillai, and thanks for joining. Dr. Anish is a DNRB in neonatology, and he has also done his fellowship in neonatal and perinatal medicine from Canada. And Dr. Anish has done his fellowship in nutrition from Vancouver, Canada. So, Dr. Anish is currently working at Motherhood Hospital as a consultant neonatologist, and his special area of interest is neonatal nutrition, ventilation, and quality improvement. He has more than 30 publications, and he is also a national and international trainer for advanced neonatal resuscitation program. Welcome, Dr. Anish. And we have our second presenter for the case is Dr. Sharanya. Dr. Sharanya has done his MD pediatrics. After that, she has pursued fellowship in neonatal and perinatal medicine from Calgary, Canada. And she has also done advanced management program in healthcare. So her special area of interest is neonatal resuscitation, lactation, and also the management. So she is currently a national coordinator for NNF and NRP, and she works as a consultant neonatologist at Sri Ramakrishna Hospital, Coimbatore. So welcome both of you, and I request Dr. Anish to start the first case.
Thank you for the introduction, and thank you all the senior faculty for joining us. I'll just start with sharing the screen. So the whole purpose of this session is to share a case that was very challenging for us. Not a very critical baby, but complete diagnostic dilemma. And this was a typical case where you speak to 5 senior colleagues and everybody gives different opinion. Somebody will say, do this, do that. So there was a complete lack of consensus. And we'll go through the case. We can have a little bit of interaction in between also, and as well as the end. So this was a very recent case that came to us a few months back. So going to the history, this was a full-term baby of VK, born to a primary mother, 32-year-old, 38-week gestation. Completely uneventful pregnancy, except that the mother had tachycardia in the last 2-3 weeks. So on and off, she would complain of tachycardia, heart rate more than 100. But the baby's ultrasounds would be normal. So the pregnancy was prolonged till term. And anomaly scan was good. Antenatal course was uneventful. And a baby boy was born at 3.34 kg. A cesarean section was done in view of the tachycardia. So they decided not to do a normal delivery. and the baby cried after birth, did not have any requirement for resuscitation. Post delivery, we examined the baby and shifted to the room with the mother. And around 8 hours to 10 hours of life, the baby was noted to have some soft tachypnea, but otherwise pink and active. We thought we'll just monitor because the baby looked active, was feeding well, and passed urine. And after 2-3 hours, again, when we checked the baby, the slight retractions had increased. RR was now 80, still maintaining saturations. But at this point, we felt that something is unusual because it was a previously well baby, and 6 to 12 hours of some minor deterioration had started. So we shifted the baby to the NICU, sent baseline labs, and started very minimal oxygen. The baby only required 2 liters per minute. All this while baby was on full feeds. After coming to the NICU, we put in an orogastric tube for feeding just in view of distress. X-ray test was done, which showed, probably a small fissural fluid, but otherwise well expanded lung. There was no evidence of pneumonia or any other infection. And the following day, the baby was off oxygen. So after 24 hours, the baby was off oxygen, and then 48 hours, the breathing also settled. So the tachypnea persisted for 2 days, but settled down. So this was the X-ray. So as you can see, the lungs are quite clear. Overlapping this rib, there is a small, query fissural fluid, but nothing alarming on this X-ray. So our initial impression was probably could it be early onset sepsis because transient tachypnea would be, present at birth and would slowly improve. Whereas this was a previously baby who was having a good respiratory status and things had sort of worsened after 6 to 12 hours. So two differentials were there. Could it be like a term baby with RDS? Less likely, or could it be some early onset sepsis because mother's tachycardia was there? So we sent the blood culture at 12 hours whenever the baby, as soon as the baby came to NICU, we sent the blood culture and started PIPTAS. We thought it could be probably some early onset sepsis. And CBC sent at birth was unremarkable. After 24 hours, we sent a CRP which came as 35. So there was some inflammation. But because the baby had a symptom and the CRP was positive, we thought better we do a CSF also. CSF was completely clean. So there were 8 to 10 cells, all lymphocytes with a normal protein sugar. And 48 hours, 72-hour culture came back as no growth. Repeat CRP on day 3 was 17. So it showed a reducing trend. But still there was, symptomatic early onset sepsis without much risk factors. So still things were not very clear. The family also were very educated. IT couple kept asking us that how did this infection happen? Is it bacterial, viral? And we said, this is culture negative sepsis. So we can't tell you much. We have done everything. And then probably 7 days of antibiotics we will give. So in room, the baby was again initially on full feeds. Then in NICU, we gave orogastric tube feeds temporarily for a day or two. And again from day 2 onwards, again oral feeds were given. In the NICU, baby had lot of loose stools also, but we thought it is probably non-specific. We were giving some formula milk for, to top up the mother's milk. But it was not a significant amount of loose stool. And then by day 4, we shifted the baby back. We said 3 more days of antibiotics we will do. And let us, keep the baby and mother together. Then the parents insisted that, do you want to look for more things? So we did an ultrasound, KUB and liver, which was normal. And then they wanted us to do an echo. So when we did an echo on day of life 5, the cardiologist had a little bit of a, surprise finding. He said that the coronary arteries are diffusely dilated with LMCA more than, the Z scores. These are the Z scores of the coronary artery. So LAD, RCA. So all the coronary arteries had significantly elevated diameters. So 3.4 Z for LAD, 2.1 and 2.4 Z for LMCA and RCA respectively. So this was a diffusely dilated coronary vessel with asymmetrical septal hypertrophy. And the baby did not have any cardiac examination finding. There was no murmur, good perfusion, urinary output was good. But the cardiologist said that, these things I have seen a lot during COVID, and you start this baby on low dose aspirin. Otherwise, the baby can have a stroke or, an aneurysm. This is very dilated. It is almost, double than what I expect. So then we were all surprised, because this was a incidental finding for us. Not completely incidental because the baby had a symptom, but we caught it during an improving picture. Had we caught it when the CRP was 35 in a baby who is symptomatic, we would have, have a different approach. But this was an improving baby. So here was our dilemma. and I would take a minute, pause to ask you guys in terms of your opinion, what should be the next step in managing this baby who is now sort of, on the improving course, but we have found this significant dilatation of the coronary artery. Should we wait and watch if the baby is asymptomatic? Should we give IVIG, low dose aspirin, as per the practice that we used to do during COVID times when we saw this inflammation and coronary dilatation? Should we run a further test to find out actually what is it, or just give IVIG alone or aspirin alone? So can we have the poll, please?
Swastika?
Yes, ma'am.
Yeah. Full question.
Okay, okay. So I am launching the first poll now.
Requesting audience to please reply. What should be the next step in the management? Wait and observe if symptomatic, give IVIG and low dose aspirin, run further blood tests to determine the etiology, or give IVIG alone.
So everybody put their opinion, please. There could be more than one right answer also, but you all can choose the best option that you feel is the right option.
Can we look at the call, Swastika?
Ma'am, should I pause the poll?
Yes, pause it.
Okay, okay. So, and should I go to the next question now?
No. You put
Okay.
the what is the answers.
Okay, okay, ma'am.
So 33% are into the opinion, wait and observe if asymptomatic. 17% are into opinion, give IVIG and low dose aspirin. 50%, that is almost half, are telling run for the blood test, not to ignore whatever you have found, though accidentally, to determine the etiology. And nobody is if to give IVIG alone. Yeah, thank you.
But how many replies in the platform? Total reply.
That I don't know, sir.
Yeah,
So
that
that we will evaluate at the
validity.
end of the session, yeah, by
Yeah.
Swastika. So we can now further. Can we move further?
Yeah.
Yes,
Swastika, do you
So
have answer? You can reply right now. Otherwise, if you need some time for evaluations, we can go further. Yeah, Anish, go ahead. Yeah.
yeah. So even we have two, full-time cardiologists in our hospital, and both of them had a differing opinion. So even one cardiologist said that you can't ignore this; it's very much there. The other cardiologist said that just, wait and watch. This might resolve on its own. So we were, also stuck. But then we also went with option C. We thought, let's at least find out, is it only cardiac dilatation or is there more to this case? So we set a marker for, we had to revise our neonatal COVID cases, which we saw in 2020, 21, 22. All the cases we sort of thought, let's send all the inflammatory markers. So we resent the CBC, CRP, LDH, ferritin, PTA, PTT, COVID antibodies. The inflammatory markers did come raised, but because the baby's, CRP was coming down, it was not terribly high. So the ferritin was 700, LDH was 742, D-dimer was slightly elevated, 457. So things were showing that there is some ongoing inflammation, but this was our first time, so we didn't know whether this is coming down or going up. And the COVID antibodies came positive. When we asked the mother, she said that she did have a viral respiratory infections, in the last trimester, but they had tested for the COVID swab. So she was actually COVID negative twice. I mean, considering whatever limitation the swab test has, but she had tested herself during pregnancy. So there was a history of respiratory infection as well. So now we had some more information that, this was actually a COVID antibody positive case with some inflammatory marker and with coronary artery dilatation. And then the question was, does it fit with neonatal multi-inflammatory systemic inflammation or not? So does it fit in the diagnostic criteria? So this is the second poll. So we can have the second poll, please. So
Swastika?
yeah, so the definition of multi-inflammatory inflammatory syndrome, neonatal and child, has had a few, changes since 2020 was the first definition. Then it got updated. 2023 it got updated again, and there are some minor modifications for a neonatal MISC. We are more, familiar with the pediatric or a child multi-inflammatory system. So. I would like everyone to type that what is the diagnostic criteria for MISC. So it includes all of the following except. So there is one wrong answer. So I want everybody to please poll for this and find the wrong answer amongst these four, which is
Swastika,
not.
can you put the second poll question? Swastika, are you there?
Yeah, it's come up.
Yeah, okay, fine. Mhm.
So multi-system inflammatory syndrome in neonates, that is what we want to know. So the diagnostic criteria for MISN includes all of the following except. So choose your single choice. This is only one right answer here. So can everyone just press the right answer button? So last 5 seconds, everybody, whoever is not put in the answer, please go ahead and type, click the option. Which of the following is not a criteria for MISN?
Can we have answers? Swastika? Network lead. So the answer here is it can be except low fibrinogen and D-dimer or except rashes and rashes on the hands and feet, which has been answered by 67%. Majority feels that all are the criteria for MIS-N except rashes and rashes over hands and feet. Yeah.
Okay. So to clarify, this MIS is an inflammatory syndrome, right? So basically the fibrinogen and D-dimer levels will be high in MISC, and that is how actually we differentiate this from HLH. So if there is a severe hyperinflammatory syndrome, suppose a baby comes with 5 days, 10 days fever and everything is elevated. So HLH, hemophagocytosis, will have a low fibrinogen D-dimer. MIS will have a normal or a high D-dimer. So C is the right answer. Rashes may or may not be. So rashes are not a obligatory or a compulsory criteria, but it is comes in the one of the clinical criteria. So we'll go through the definition after 1 or 2 slides. So anyway, so after we involved our ID team, our infectious disease team, and we had a dilemma like we, in the first poll question, should we give IVIG and aspirin, ecosprin both? Because that is what the traditional guideline would say. But because the baby was on the recovering term, considering the side effects of aspirin versus IVIG, our neonatal team was more comfortable to do only IVIG. So we gave IVIG 1 gram per kg. By the time it was already day 5. So this echo was done on day 5. So baby was recovering. So we gave IVIG. Stopped the antibiotics on day 7 because it was a culture negative early onset sepsis. Plus we had an antibody positive for COVID. At discharge, we deferred the vaccination because IVIG was given just for a short time, and we discharged the baby on day 9 of life. On follow-up, baby had good weight gain. We did a repeat 2D echo after 10 days, which showed normalizations of the coronary artery. So all the Z scores had come back to normal. So the coronary artery dilatation had recovered quickly. We don't know whether it was because of IVIG or it was natural, because as I mentioned, one of our cardiologists was saying that don't give anything, it will come back to normal anyway. But because the family was very stressed out, they were asking multiple times what is the, side effect. So it was a mix of evidence-based plus practical plus social decision that we took at that time. And on 2 month follow-up, the baby is currently thriving well. Social smile has come, the baby is completely stable. So this baby was never very critical. But because of that incidental finding and the lab markers that sort of supported, we had a lot of dilemma and confusion in terms of what to do. So coming to the second audience poll that I did, what is the diagnostic criteria? So 2023 they have updated the diagnostic criteria for neonates, where clinical criteria are not mandatory. So fever may be there for pediatric MIS, but for neonate it is not very similar, not compulsory criteria. Inflammatory markers we discussed, so CRP, ferritin, LDH, all these markers, ESR will be elevated. Cardiac, there could be dysfunction, elevated troponin or coronary dilatation. Mucocutaneous rash is a part, shock is a part, and GI symptoms like vomiting or diarrhea, and hematologic criteria like cytopenia, so leukopenia, thrombocytopenia, etc. So all criteria need not be there. Generally, clinical plus 2 or more is sufficient to diagnose it. So the diagnosis has sort of evolved, and right now you have to actually search to find a definition. I had to do a lot of search to find a proper definition, whereas during COVID there were 10 definitions. Every article would have MISC or neonate, pediatric, everything. So what does management principle say? So again, there is no guideline for management. It is mainly supportive plus IVIG and then low dose aspirin depending on the significance of coronary dilatation. This is mainly to prevent stroke. Steroids, again, not as a part of protocol, but off label, and some studies have used steroids for this as an anti-inflammatory, and antibiotic again as a supportive role, mainly for secondary infection, because this MISC is considered to be a post-viral phenomenon, not a post-bacterial phenomenon. So what all dilemmas we had? So we were completely, confused for that few days. So we involved a multidisciplinary team. So 3 neonatologists, one in pediatric infectious disease specialist, our 2 cardiologists and microbiologists. So we would have a discussion in terms of deciding what is the best step. Obviously, the family being the main person during these discussions. IVIG, aspirin, or both, or should we just wait? So it was, like I said, a balance of safety in terms of patients versus a practical decision. Because again, this is a chat GPT era, it's a AI era. So, before we could tell the family only, they asked the doctor what could be worse. So they already knew that, a coronary artery dilatation can lead to stroke. It could be a sudden event, sentinel event. And they also knew the medical risk of medicine. So counseling was a little different because it was a super, highly educated family. They knew everything from, the problem, side effects, IVIG, aspirin, what to give, what not to give. So they were already, on top of things before we could prepare and discuss with them. And the second dilemma we had was when to discharge them. Should we do a repeat echo, document that the coronary arteries have normalized, then discharge them, or should we just discharge and do a follow up like we did? So lot of unclear, thoughts were there, and until the 2 week follow up happened, we were still unsure that what to do, and should we later on we might have to add ecosprin. So a lot of uncertainties were there. What went well, I think we were completely transparent in terms of family communication. So we told them that this is a gray area. And we have spoken to 2, 3 people. The ID consultant cardiologist met them independently and with us as a team. And we told them that we are trying to find out the best possible solution for your baby. What could be done differently? I think this again, probably not treating with IVIG also would not have changed the outcome, is what I feel. Whether it would have come back to normal in 2 weeks, 4 weeks, we don't know. But the main learning point was that this was something that we had completely forgotten. That this MIST and MISN used to happen so frequently. We have reported cases, we have all seen so many cases, but this had gone out of our memory. And COVID swabs nowadays nobody does. And actually, when we wanted to do a COVID PCR, a lot of our labs refused. Finally, we thought we'll do the COVID antibody because it was a very early onset sort of a picture. And that is how we decided to send the COVID antibody. That also from all the labs, 1 or 2 labs we had to outsource and send because our own lab said that we have stopped doing COVID antibody because of the lack of volume. They don't want to do it anymore. So post-viral inflammation is still possible. That was our, biggest learning for us as a team, because typically we would all blame it as the early onset sepsis. Easy option is to treat for 7 days and forget about it. But post-viral is still possible and it can mimic infection. That was the main thing. So I will open this forum for discussion. I'm going to stop sharing my slides. and we can have some discussion for 5-10 minutes.
Yeah, any questions? You may put it in the chat box. By the time we get chat box questions, Dr. Anish, I would like to ask one thing related to like, did you get the mother's antibody?
No, so mother's antibody we didn't get because the mother was well by that time. We thought that we will do in terms of measuring the titer, like mother's antibody titer, and if the baby's
Can it
titer is
be
same.
just intrauterine transfer because mother was vaccinated or having a past infection, having the antibodies?
Correct. So the baby's antibody titer was quite high. It was above the vaccination level. So we did check that. Mother's antibody titer we wanted to send out of academic interest. But by the time everything was done, so the parents were like they were ready to go home by the time. So we ended up not sending, for the cost and other reason. But we did think
Unnecessary
about
hours.
sending it. Yeah. We were very curious to send it actually.
Yeah, because that is the one thing. If it's a fourfold rise, then you just stamp it as not the transfer, and it's actually the infection and the post-inflammatory things. Because many a time it even used to happen at the time of COVID after vaccination. Again, in the sick after the
True.
vaccination era. So baby's antibody used to get positive, and then we were again getting confused to picture, yeah, hai, what is it? Actually, is it a miss N or it is just a transfer of antibodies post vaccination?
Right.
I don't know, itna like lamba coverage hoga. The vaccination, the all
Was few years back, many years
22
back.
and 4 years, yeah. The titer would have gone quite down.
Hmm.
Okay, any other question or shall we move for the second case? Swastika, is there any question in the chat box?
Anis,
No, ma'am, I've just checked. There is no question right now.
Okay,
Anis,
so I
Anis,
Yes, sir.
just
Yes.
I wanted to ask a question. Did you check how long it takes coronaries to become normal? Is there any literature
By
available?
No, so, sir, literature basically, I didn't specifically look for that part, but I expected it to slowly come down. Like I told the family we'll do one at 2 weeks and then maybe once at 3 months. So, my general thought process for this family also was that it shouldn't come down so quickly. But it came down within like 2 weeks' time. So, we were also a little surprised that it came down to normal completely now. And it was done by the same cardiologist, same measurement, same machine, so that there was that way good standardization. And experienced people, cardiologists, like it was a senior cardiologist at a center. Exactly.
Great. Any other query, question, or shall we move? I think there is nothing. So, thank you, Dr. Anish. It was wonderful presentation. At the end of the session, if we have any questions, then we'll ask you again. And right now, I request Sharanya to present the second case. Dr. Sharanya, over to you.
Yeah, thank you. 1 second. Is my audio clear, everyone?
Yeah, you are.
No. So I'll be presenting the second case series in this Neonatal Pathshala. So I took up a slightly different case series. This is about prenatal and perinatal genetics. I'll try to make genetics as interesting as possible. So I have two cases today, a series of two cases. I'm not going to talk about the clinical picture because we're going to concentrate more on the genetic aspect of it. So the first one was Mrs. M, 29 years old. She had a bad obstetric history, gravida 5 and abortion 4. All her previous pregnancies were spontaneous conceptions. The first pregnancy was a early first trimester spontaneous miscarriage. The second and third pregnancies were very similar. The anomaly scan done at 20 weeks showed multiple cysts in both the kidneys, and they had been advised termination. This was done elsewhere. A fetal autopsy actually had been suggested, but was not done for both the pregnancies. The fourth pregnancy again was a first trimester spontaneous miscarriage. Now, parents were evaluated at Mumbai for recurrent pregnancy loss. A whole exome sequencing was done in quite a renowned lab, and it turned out to show that father had a heterozygous mutation for the polycystic kidney disease type 4. So it was reported as being likely pathogenic. So if we all remember the polycystic kidney 4, it is an autosomal dominant disease, and it's usually an adult onset disease. Mother's whole exome was actually reported as completely normal. Because it was a whole exome, they had also reported that there were no other pathogenic variations unrelated to the phenotype also in that particular report. So if we have to think about, just pause here and think about, so far, are there any hits and misses? One thing is, I think with the recurrent pregnancy loss, genetic testing could have been suggested a little earlier, probably even after the second or the third loss. Now, the gene picked up, like I told you, is a autosomal dominant PKD gene, which is usually adult onset. So does it really explain the fetal loss, especially two fetal losses? And we did not find any fetal MRI or anything done. It was just an ultrasound report of kidney cysts. Also, there did not seem to have been a detailed counseling done by a genetic counselor. So at this point, the thing is, the fetal findings, were they even fatal? Did they even need a termination? And were the losses related to this? We're not sure. Now, this pregnancy, early pregnancy, was supervised in Mumbai, and they had been suggested amniocentesis given the bad obstetric history, but they were also explained about the high risk of damage to fetus due to amniocentesis, and parents did not go ahead with it due to that. Now, the anomaly scan was reported as normal. So the family considered everything to be going well so far, because the kidney cysts that they had been told about in previous pregnancies was not picked up. So they moved to Coimbatore and registered with us at 32 weeks. Otherwise, after 32 weeks, it was uneventful, and the growth scans were all normal. She was induced at 38 weeks, had a normal delivery, a baby boy, 2.7 kilos, who roomed in with the mother, was doing quite well, was on breastfeeds. Phototherapy was started for minimal jaundice at 60 hours, and at 69 hours, he was picked up with a little bit of hypothermia. Actually, not a little bit, quite a bit of hypothermia. Now, initially, as we always think about, we thought maybe it was due to exposure to phototherapy. And even after rewarming the baby under a warmer, because the phototherapy was initially given in the mother's side, even after rewarming, the baby remained to be very, very lethargic with a very poor feeding. So he was shifted to the NICU. And the sepsis screen that was initially done was negative, but the baby did not improve, continued to be lethargic. The blood gas done at admission showed metabolic acidosis with elevated lactate. And we went ahead with an IEM workup, which showed significantly elevated ammonia levels. So a TMS and GCMS were sent. And the baby was started on sodium benzoate, L-arginine, and the IEM cocktail. Because at that point, we did not know what we were dealing with. It was probably an IEM, but what kind of an IEM, we were not sure. Now, we just decided to have a detailed relook at the history for anything that we might have missed. So this was a non-consanguineous couple. And when we looked at the family history, we found that there was actually a history of 3 unexplained neonatal deaths on the paternal side of the family. And there was actually one child on the same paternal side who had an undiagnosed metabolic error, who was actually picked up by, was under follow-up with Dr. Anil Jalan, and he was on treatment with coenzyme Q. Detailed workup had been done, but what kind of a metabolic error had not been picked up. Now, this baby in the NICU meanwhile, was deteriorating. He was ventilated on day 2 of admission. And though there was a slight improvement in metabolic acidosis, his encephalopathy was worsening day by day. And the ammonia levels were also increasing. So we started peritoneal dialysis on day 8 of life, and the serial ammonia levels were monitored. There was a little bit of waxing and waning of ammonia, and the frequency of peritoneal dialysis was adjusted according to that. But his encephalopathy did not seem to get better at all. So we did go ahead with a whole exome sequencing. This turned out to be positive for a pathogenic variant, that is the gene associated with classic citrullinemia. It was homozygous. So the parents were counseled regarding the baby's current morbid condition and the grave prognosis. By then, the encephalopathy had really worsened. And we did counsel them for withdrawal, but the parents wanted to continue care. Now, at this point, the genetic dilemma or the conundrum for us was the ASS1 gene, which is the pathogenic gene for citrullinemia, had been detected in a homozygous state. That means it could have been picked up in the parent's whole exome, or should have been picked up. So, in discussion with the MFM expert, we decided to review the previous genetic reports. Now, the parents' genetic report actually said that there was no other pathogenic variant unrelated to the phenotype, that is the kidney phenotype. There was nothing unrelated also which was picked up. So, were we missing some link here? So now I would like to put across the poll question. At this point, we are dealing with a neonate who has a grave prognosis, who's deteriorating day by day. What do you think would be the next best step in management? To counsel parents regarding the critical nature and withdrawal of care, should we tell them that this new mutation that was picked up in the baby could be de novo and that the recurrence risk in next pregnancy would be very low? Or should we assume that there was some undetected mutation in parents' previous tests and should we ask them to come back later for retesting? Or should we retrieve the old data of parents and reanalyze?
Dr. Swastika, can you put up the call? Swastika? Yeah.
Yes, ma'am. Is it visible?
Yeah, it's
Yep.
visible.
Okay.
It's not the poll question, Swastika. You got the wrong poll question.
It is a wrong question, ma'am.
The other question. This is for the second one.
So, ma'am, should I keep it or should I just change it, ma'am?
No, there is another poll question. If you see,
Yes,
I've
yes.
sent you two
Then
questions,
I'm
right?
changing the question, ma'am.
Yeah, yeah. Yeah. Can you show us the answers, Swastika?
What are the answers? Just post the poll and just check what are the answers.
Ma'am, should I end the poll now?
End it.
Okay.
Done? Answers, Swastika?
Yes, ma'am.
Can you reflect? Can you show the answers?
Yes, ma'am, sure.
Yeah, so due to the likelihood of some undetected mutations in parents' taste, advise them to come back for testing at a later date. So that has been answered by 25%, and 75% people believe that retrieve all whole genome exome sequencing and reanalyze. So then if answer 4 is for 75% patient.
Yes, I think that's the right answer. I'm so glad that most people think that we should retrieve the data. And that is, sorry, my slide is not moving. 1 second. Yeah. So that is what we decided to do. We decided to reanalyze the data, the old data. So we asked the same lab to process the data again, but this time we described the phenotype as metabolic errors. And strangely, both parents turned out to be heterozygous for the same gene that we had detected, ASS1, the classic citrullinemia gene. But our with what we thought was there was a strong family history of neonatal deaths, and we did not want to miss any other pathogenic variant that we could have already missed because this one had already been missed. So what we did was we procured the raw data, the genetic data from that lab, and sent it for reanalysis to a different lab. And what did we find? So the babies, we sent the baby's sample and the parent sample. We found that the baby was, as reported in the other lab, homozygous for ASS1, but he was also heterozygous for a lethal encephalopathy gene, which had been reported to be either autosomal recessive or autosomal dominant inheritance, but it was only a gene of uncertain variant of uncertain significance. Mother was heterozygous for citrullinemia, but she was also heterozygous for glutaric acidemia and for the same lethal encephalopathy gene. The dad was heterozygous for citrullinemia gene, and he was heterozygous for the previously detected the PKD4 gene and heterozygous for a different nephronophthisis gene as well. Now, just to put things a little bit clearer in perspective, so the citrullinemia gene, which is the pathogenic one, had been picked up in a heterozygous form in both mom and dad, and homozygous form in the baby. The glutaric acidemia, which is likely pathogenic, was picked up only in mother. The lethal encephalopathy, which is only a VUS, a variant of uncertain significance, was picked up in mom and baby, but in baby it was heterozygous, both mom and baby. The kidney gene, the polycystic kidney gene, had been picked up in a heterozygous state only in the father, and the other kidney gene also only in the father. So the previous two fetuses that we had lost, the terminations that we had done, we did not have a genetic testing, so we can only assume whether they were positive for these genes. Just quickly to put things a little bit clearer, what is a pathogenic gene? It is responsible, definitely responsible for causing disease. There is ample research to support it. Likely pathogenic is probably responsible, but there's still not enough data to support it. A variant of uncertain significance is we cannot confirm whether it is significant, and we need more scientific research to confirm or refute its association. A likely benign gene is probably not responsible for causing disease, but we do not have enough research. A benign, completely benign gene is not responsible for causing disease. So these are the classifications that we get in a genetic report. Most of us are already aware of it. Now, what is the interpretation that we can get from this reanalysis that we did in a different lab? So genomics is always evolving, and there are so many new genes that are being reported and picked up. Now, phenotypic correlation alone sometimes might not be sufficient, just like we saw in this case. So a phenotype of a kidney gave us a different picture, and a phenotype of a metabolic error gave us a different picture. Especially when we're dealing with recurrent pregnancy losses, we need to be a little more careful with phenotypic correlation. And we need to understand that the kind of analysis that is done and the labs which do the tests, they are of different categories, and it's very, very important to pick and choose as well. And history taking, the good old history taking, is very, very essential, because if the neonatal deaths had been picked up probably before the first WAS was done, maybe we would have looked for metabolic errors as well. So with this history, the option for this couple probably would be a donor gamete, a donor embryo, or prenatal genetic testing. So, like I already mentioned, the family history could have probably led to a previous picking up of the ASS1 gene. Now, the other dilemma here is the previous losses that we had, the losses and the terminations that we had, were they probably not related to the kidney phenotype at all, because the gene was picked up only in the father and it was actually a adult onset kidney disease. So we do not know, we can only introspect. Now, this testing, what does it add to the family? At least in the next pregnancy, we can be a little more careful. We can advise, early amniocentesis and testing the fetus for all the pathogenic variants. And if we had not done the reanalysis, the problem is that we probably would not have advised them for a donor gamete. So this family, which has already endured a lot of, trouble and pregnancy losses, would have probably gone through another terrible loss. So moving on to the second case, I'll try to make this very short. Do we have 10 minutes, Biraj? How much time do we have?
Yeah, that's fine. You may.
Okay. Now, the second case is Mrs. R, 26-year-old G2P1 mom, non-consanguineous marriage. This was the first pregnancy was a spontaneous conception. The antenatal scans were significant only for polyhydramnios, onset from 26 weeks. At 31 weeks, this is the previous pregnancy, she had cervical incompetence and went in for preterm labor. It was a female baby, normal vaginal delivery, birth weight of 1.3, shifted to tertiary center for NICU care. Had RDS, needed surfactant, but needed prolonged ventilation, and on day 10, day 11 of life showed deterioration in terms of respiratory and neurological. And an MRI brain done showed grade 4 IVH with ventricular dilatation and some leukoencephalomalacia. Baby succumbed on day 18 of life. So this was the previous pregnancy. So for this current pregnancy, she was booked with us. It was a spontaneous conception. So we looked at all the antenatal records and the discharge summary from the previous unit. It seemed to be a preterm delivery due to cervical incompetence, and death probably due to complications of prematurity. The only screening that was done was for ANA, and it turned out to be positive. She was put on appropriate drugs for the same. Torch was negative. Now, in this pregnancy as well, she had borderline polyhydramnios at 30 weeks of gestation. But what was alarming was at 31 weeks, we started to notice some contractures appearing in both the wrist joints. An emergency LSCS was done at 32 weeks because she had preterm onset of labor. Baby was completely limp at birth, required extensive resuscitation, and with very low Apgars, 2, 4, and 6. Birth weight was 1.8 kilos. There was no obvious facial dysmorphism, but there was profound hypotonia and complete areflexia. There was absolutely no spontaneous respiratory effort at all. And we noticed significant contractures at the wrist joints and knee joints. So because of the significant hypotonia and areflexia, we did a neurosonogram immediately, which showed periventricular echogenicity, cortical thinning, and some ventricular dilatation. Whether to do an MRI brain or not was under discussion at that point. Now, at this point, we are dealing with, again, a child who has a very grave prognosis. So what do you think would be the next best step in the management of such a neonate?
So, Stika put up the full question. Yeah, so what is the next best step for this baby? Counsel regarding grave prognosis and withdrawal of care. Do a clinical exome sequencing, do whole exome sequencing, or relook at the history of previous pregnancy for clues. Swastika, please stop the poll and then just reflect the answer. Yeah, so 50% says that do a whole genome sequencing. 17% are into opinion to do a clinical genome sequencing, exome sequencing, and 33% are into opinion to relook at the history of previous pregnancy for the clues. That is a learning from last case. Yeah.
Yeah, so I think the easiest thing at this point would have been to do a whole exome sequencing. But what the reason I picked up these two cases is for us to reflect a little bit and say, if you see from the previous case, right, even when we send a whole exome, though we think that the whole exome is being sequenced, it's not a whole genome, it's a whole exome, but how much of the phenotype is going into this analysis, right? And so is it going to be better to have a better clinical phenotype before we ask for a whole exome? So we decided to actually take option 4, relook at history of the previous pregnancy. So when we did that, what were the clues that we got? There was polyhydramnios in both pregnancies. Cranial ultrasound findings were almost similar. So we did have a high degree of suspicion for genetic basis. So we asked the parents to bring all the medical records that they had at home, every single piece of paper that they had. And we spent a considerable amount of time going through all that. The discharge summary was there. We perused, looked through it completely. But the good thing was we actually found some medical bills in the file when we were going through the entire records. And there we stumbled upon one small bill for whole exome sequencing. So that means the previous baby had also had a whole exome sequencing. And we contacted the previous treating neonatologist because the report most often goes to the treating neonatologist. So that way we retrieved the previous report of the first baby. That actually showed a gene for congenital hypomyelinating neuropathy type 3. It was reported as a variant of uncertain significance. So it was just a WOOS. So we do not know if it is really pathogenic at all. There was another mutation as well, but this was what was of significance because looking at the clinical picture, congenital hypomyelinating neuropathy seemed to fit in with the clinical picture of the baby that we were dealing with as well, because there is neurogenic muscle impairment which starts in utero, which can explain the contractures that we had seen. The affected individuals are at birth, the neonates have severe hypotonia and often end up with respiratory insufficiency or failure. And if at all they survive, they have profound impaired psychomotor development later on, and very commonly leads to death in early infancy or childhood. This is an autosomal recessive condition. Now, this child continued to have profound hypotonia with complete areflexia. The clinical features again, so because it looked like a central neuromuscular disorder, we just did CPK for completion's sake. It was within normal limits. The previous sibling being encephalopathic with this exome revealing a WOOS, we thought that we should probably put this as a clinical phenotype and ask for a whole exome. So we did counsel parents and sent whole exome with deletion duplication and mitochondrial genome along with DNA storage. Because it was a grave prognosis, we withheld resuscitative measures and the baby succumbed on day 6 of life due to severe respiratory failure. The genetic report that we got later on showed that there was a homozygous mutation for the same gene, the congenital hypomyelinating neuropathy type 3. And this time it was reported as pathogenic, not even likely pathogenic, it was reported as pathogenic. So the same gene that was reported a year back as a variant of uncertain significance was reclassified as pathogenic in a matter of 1 year. Now, what did we do? We did a multidisciplinary counseling with the MFM geneticist and the neonatologist. We suggested targeted testing because it seemed very, very likely that we just needed to test that particular gene in the couple. So a carrier screening was done for the couple and karyotyping as well. And it turned out that both of them were heterozygous for the same mutation. Karyotyping was normal. So for this couple as well, we counseled them in detail about the options for next pregnancy, which could be again a prenatal genetic testing or going ahead with the donor gamete. So from these two cases, what are the take-home messages, or what is the clinical dilemma questions that all of us should remember? So it's very simple to give a phenotype and ask for a clinical exome or a whole exome, but to read the report is very important. So even a variant of uncertain significance, which is reported as a WOS, when it very significantly correlates with the baby's condition, I think we should take it as a significant mutation. So what the way the genetic database works is, because we went and read up in detail about this. So when there are 2-3 pathogenic correlations with a WOS, then the report is changed as, maybe a few months later, a WOS is changed into a pathogenic variant. So all it takes is for you to report. If you have a WOS and you report it as correlating significantly with your clinical picture, then that report goes to make it a pathogenic variant. So it's important for us to get back to the lab and let them know that this looks significant. Very important to have a multidisciplinary approach. So don't just hand over it to the geneticist and leave it aside. It's important that all of us get involved at every step: the obstetrician, the MFM expert, the neonatologist, and the geneticist. And it's important for the team to meet before meeting the family, because genetics can be so confusing. So we need to know exactly what is the final message that we're going to give the family, and what is the advice that we're going to give them, especially for subsequent pregnancies. So, with a lot of next generation sequencing coming up, accurate genetic diagnosis is becoming more and more simple and easy, but it's extremely important to interpret your results properly. So to have a panel of people, clinicians and geneticists to make good interpretation, because any genetic diagnosis can affect the immediate and long-term management of critically ill babies in the NICU. And when you make an accurate genetic diagnosis, you are probably, making a good decision for the parents' future reproductive choices as well. So I would like to say that the goal of prenatal diagnosis most often is not to generate perfect babies. It is like these families that we're discussing about. If we can try and alleviate their misery, that is what is most important. Thank you. And if there are any questions, I would like to take them now.
Thank you, Saranya. It was really a thought-provoking and really a challenging cases which you guys have handled. And is there any questions, Shwastika? Please update us either in the chat box or just unmute yourself and just update if there is any question. Any questions from anyone, faculties?
There's nothing in the chat box.
Yeah, this is basically faculties link. So if there's any question, then Swastika will be updating in the chat box from the delegates link.
No, ma'am, I have checked it already. There are no queries from the participating doctors, ma'am.
Okay.
Saranya, only one question.
Yes, sir.
Once you know the mutation, why did you do a whole exome sequencing for the parents? Only Sanger sequencing should have been okay.
We did the targeted genes. That was not a whole exome. You mean the second one, no? The second case.
Then it's called Sanger sequencing.
Yeah, sorry. Just Sanger sequencing. Only the targeted gene, not a whole exome. Yeah.
Okay.
So excellent presentation, Dr. Saranya, and it was wonderful to listen from you. So our participants can learn so many things. Now Dr. Somsekhar is here.
Hi.
Somsekar sir.
So
Dunya, you
both of
stop your
them
presentation if possible. Stop sharing. I think it's.
Oh, sorry. Yeah.
both of them have done excellent presentation. Then one is a more clinical one, which we have often seen but not recently, and this is a completely different way of looking at genetic tests and interpreting them. So it's very important for us to understand how these things work, and the amount of time that you need to spend on such cases is really large. So it is important for us to take a pause and look at the history, look through all the records, and that makes it more important, more easy for us, or more then it is possible for us to reach a proper diagnosis. As Dr. Rajesh pointed out, we should know exactly what kind of tests are we proposing. So just doing a random list of tests can cause it to be more confusing. So thank you very much, Dr. Saranya and Dr. Anish, for doing the cases and helping us all.
Thank you.
Thank you, sir.
Thank you, Dr. Anish, Dr. Rajesh, Dr. Somsekar sir, Dr. Biraj, and Dr. Saranya, Dr. Ronak, and Clarinet team.
Yeah, thank you all. And we shall end the session with two major learning points. That is, one is the history taking is must, and going back to the records is important. And gray area and dilemma is always going to be there. Post viral inflammation is still exist. And with this I would like to end. And yeah, Clarinet, thank you all, thank you Sharanya, thank you Anish, thanks everyone.
So, thanks to all the interest present here. Clint is really glad to have all these brilliant people together in session today, and I hope you all enjoyed the session today. So, with everyone's permission, I'm concluding the session in here for today, and looking forward to host you again. Thank you so much, everyone.
So we have a next week focus session next Wednesday. So
That is
please
Okay.
do please generate the flyer and the link today so we can circulate
Okay,
in
sir.
the
I will.
yeah.
I will
Yeah.
let the quarantine team know. They will
Mm.
be going through with it. So,
Thank you everyone.
thank you. So, thank you. Have a good day ahead.
Yeah.
Thank you.